Hey everyone, let's dive headfirst into a rapid-fire revision of UPSC CMS previous year questions. We're going to be tackling the most important, high-yield points from questions 1 all the way through 20.
All right, let's jump right in. Get ready to test your knowledge and really lock in these concepts for your exam.
First up, question 1. In a sutured surgical wound, the process of epithelialization is completed within A. 24 hours, B. 48 hours, C. 72 hours, or D. 96 hours. The correct answer here is B. 48 hours. So think about it like this. In a nice, clean, sutured wound, those epithelial cells are eager to close the gap. They just migrate from the edges and usually have the job done within about 24 to 48 hours.
Okay, let's move on to question 2. Extensive surgical debridement, decompression, or amputation may be indicated in all the following clinical settings except A. Progressive synergistic gangrene, B. Acute thrombophlebitis, C. Acute hemolytic streptococcal cellulitis, or D. Acute rhabdomyolysis. The exception here is B. Acute thrombophlebitis. The key difference is medical versus surgical management. Acute thrombophlebitis is treated medically with things like anticoagulation, while all the other options are aggressive infections that absolutely demand surgical intervention. Next up, question 3. Which one of the following bacteria is classified as a facultative anaerobe? Is it A. Pseudomonas, B. Bacteroides, C. Escherichia, or D. Clostridium? The correct answer is C. Escherichia. And remember, facultative just means it's adaptable. E. coli is a perfect example. It'll use oxygen for respiration when it's around, but if there's no oxygen, it can easily switch over to fermentation to survive.
On to question 4, which asks for the statement that is not correct regarding a sebaceous cyst. A. It has a punctum. B. Treatment is incision and drainage. C. Found on hairy areas of the body. Or D. Not found on palms and soles. The incorrect statement is B. And here's the crucial point. You do incision and drainage for an abscess. For a sebaceous cyst, you have to completely excise the cyst and its wall to prevent it from just coming right back.
All right, question 5 is a matching question. We need to pair the carcinoma in list I with its characteristic in list 2. The correct code is A, which is 4123, so let's run through it real quick. A. Seminoma testes is famously highly radiosensitive, so that's A4. B. Carcinoma prostate is hormone-dependent, so that's B1. C. Basal cell carcinoma rarely spreads through the lymphatics, which is C2. And finally, D. Malignant melanoma. Its prognosis is all about thickness, Breslow's thickness, so that's D3.
Now for question 6, tumors of the anterior mediastinum include the following except A. Thymoma, B. Lymphoma, C. Germ cell tumor, or D. Schwannoma. So which one doesn't belong? The answer is D. Schwannoma. And this is a perfect time for that classic mnemonic, right? Remember the 4 T's of the anterior mediastinum? Thymoma, teratoma, thyroid, and terrible lymphoma. Schwannomas are nerve sheath tumors, and you're going to find those in the posterior mediastinum.
Question 7 focuses on a really common issue in India. The commonest cause of unilateral lymphedema of the lower limb is A. Lymphedema tarda, B. Carcinoma of penis, C. Filariasis, or D. Tubercular lymphadenopathy. The correct answer, as many of you know, is C. Filariasis. This is a key public health fact. Lymphatic filariasis from that parasite Wuchereria bancrofti is a huge cause of acquired lymphedema in endemic areas like India.
Let's have a look at question 8. The Nottingham Prognostic Index is used for A. Cancer of the stomach, B. Cancer of the colon, C. Cancer of the lung, or D. Cancer of the breast. And the correct answer is D. Breast cancer. The NPI is an absolutely vital tool for prognosis in breast cancer, and it's based on 3 key things: the tumor size, the lymph node status, and the tumor grade.
Question 9 gives us a clinical scenario. A patient has recurrent abdominal pain and jaundice. Blood tests show reticulocytosis and hyperbilirubinemia. So what's the diagnosis? Is it A. Hereditary spherocytosis, B. Merizi syndrome, C. A colidoductal cyst, or D. Sclerosizing cholangitis? The correct answer is A. The key here is just connecting the dots. Jaundice plus reticulocytosis screams hemolysis. Hereditary spherocytosis causes chronic hemolysis, which leads to pigment gallstones, and that perfectly explains the recurrent pain and jaundice.
And question 10 asks, in gallstone ileus, where does the obstruction most frequently occur? A. Duodenum, B. Jejunum, C. Proximal ileum, or D. Terminal ileum? The answer is D. The terminal ileum. This is a classic anatomy question. That gallstone travels all the way down the bowel and gets lodged at the narrowest part, which is almost always the terminal ileum, right before the ileocecal valve.
We are officially halfway through. You're doing great. Let's keep this pace up and power through the next 10 questions.
Question 11 is about pigment gallstones. The following conditions are associated with a high incidence of pigment gallstones except A. Cirrhosis, B. Ileal disease, C. Thalassemia, or D. A prosthetic heart valve. The correct answer is D. Now, while a prosthetic valve can cause a little bit of hemolysis, it's a much weaker link compared to the massive chronic hemolysis you see in thalassemia or the altered bilirubin metabolism in cirrhosis.
Next up, question 12. What is the most common route of spread in a case of pyogenic liver abscess? Is it A. Hematogenous through the portal vein, B. Ascending infection through the biliary duct, C. Through the hepatic artery, or D. By local spread? The answer is A. The key here is just to think about where the liver gets its blood. An infection in the gut, say from appendicitis or diverticulitis, can send septic emboli straight to the liver through the portal vein.
Question 13 asks, what's the most common complication of pancreativism? A. Obstructive jaundice, B. Duodenal obstruction, C. Recurrent acute pancreatitis, or D. Peptic ulcer? The correct answer is C. And this is all about the anatomy. In pancreativism, the ducts don't fuse right, so most of the pancreatic juices have to drain through a teeny tiny opening. This backup can lead to recurrent episodes of acute pancreatitis.
Moving on to question 14, the commonest major surgical complication following a Whipple procedure is A. Disruption of the pancreatic anastomosis, B. Biliary peritonitis, C. Disruption of the gastric anastomosis, or D. GI bleeding. The correct answer is A. Look, during a Whipple, a bunch of new connections are made, but the one to the pancreas is by far the most fragile. If that connection leaks, you get a pancreatic fistula, which is the most common and most feared major complication.
Question 15 gives us another scenario. A 60-year-old male presents with bleeding per rectum. A proctoscopy reveals second-degree hemorrhoids. The treatment of choice is A. Cryotherapy, B. Sclerotherapy, C. Banding, or D. Surgery. The answer is C. Banding. For symptomatic second-degree hemorrhoids, rubber band ligation is really the go-to procedure in an office setting. It's super effective and a lot less invasive than jumping straight to surgery.
Now, question 16 is an interesting one. It says, at present, treatment is recommended for H. pylori in association with all of the following except A. Duodenal ulcer, B. Early gastric cancer, C. Mulch lymphoma, or D. Benign gastric ulcer. While this is a bit of a trick because the question is actually outdated, current guidelines say we should treat H. pylori in all of these situations. So while you might find this on an old exam, just remember that in modern practice, all of these are clear-cut indications for treatment.
Question 17 asks us to define a classic eponym. Pott's puffy tumor is A. Tuberculosis of the skull bone, B. Squamous cell cancer of the scalp, C. Subperiosteal abscess associated with osteomyelitis of the frontal bone, or D. A fungating scrotal malignancy. The correct answer is C. Pott's puffy tumor is that rare but classic complication of frontal sinusitis. It causes an infection in the frontal bone itself, which leads to an abscess under the periosteum that makes the forehead look all puffy.
Question 18 is all about frozen shoulder. We have 4 statements, and we need to pick the right combination. The correct option is B, which means that statements 1, 2, and 3 are all correct. Yes, it is associated with diabetes. Yes, it can follow even minor trauma. And yes, you do need to rule out infection and fractures. Statement 4 is the one that's wrong. Surgery is a last resort, not the treatment of choice. The first line is always conservative management with physiotherapy.
Question 19 asks, which type of epiphyseal plate fracture has the absolute worst prognosis? Is it when the fractional line A runs along the plate, B extends into the epiphysis, C crushes the epiphyseal plate, or D crosses the epiphyseal plate? The answer is definitely C, a crush injury. This corresponds to a Salter-Harris type 5 fracture. It's the worst because it directly damages the growth cells in the plate itself, which can easily lead to growth arrest.
And for our final question, number 20. A 30-year-old man is in an accident. He has multiple rib fractures, paradoxical chest movement, and severe respiratory distress. What is the initial choice of treatment? A. Immediate internal fixation. B. Endotracheal intubation and mechanical ventilation. C. Thoracic epidural analgesia and O2 therapy. Or D. Stabilization with towel clips. The correct answer is B. This is a classic presentation of flail chest, and this patient is in respiratory failure. The top priority is always airway, breathing, circulation. That means we have to intubate and provide positive pressure ventilation to stabilize that chest wall and support his breathing.
And that's our 20-question sprint. Fantastic job working through these high-yield topics. Keep this momentum going in your revision, and we'll see you for the next set of questions. Keep up the great work.